20% of stable patients in paradigm had an event. 50% of the time this event was death, and 60% of these deaths were sudden cardiac deaths. So even in a carefully conducted, well-controlled, well-monitored, randomized trials like paradigm, if 20% stable patients have events, we should wait? Certainly not. So ARNI should be started, in my opinion, as early as possible in every single patient with stable HFrEF who is on ACE inhibitor, if cost is not a constraint and if potassium and eGFR is not an issue. Therefore, 2022 guidelines released just 20 days ago show class 1A recommendation to ARNI. It has moved one class up from class 1B to class 1A. Is acute decompensated heart failure any different than de novo? Certainly. Acute decompensated heart failure means a patient who is known of heart failure gets admitted breathless, hypotensive, or ill in an ICU. De novo heart failure is a patient who was not known to have heart failure before, gets admitted in a bad shape. What is the difference? The difference is de novo heart failure patients have lesser comorbidities, more precipitating factors like arrhythmias, infection, valvular incompetence, or cardiac ischemia. So they are more modifiable risk factors at the backdrop as compared to acute decompensated chronic heart failure. And on the top of all that, the de novo heart failure responds to ARNI far much better than patients with acute decompensated heart failure who are chronic.